First speaker is Dr. Bichakjian, who has been a fantastic colleague in dermatology with me, assistant professor of dermatology, really kind of a national expert in melanoma, as well as a rare cancer of Merkel cell carcinoma. So I'm very fortunate to have him agree to talk to you guys today, again, from a dermatology perspective. Thank you.
My name is Bichakjian. I am a dermatologist by training. Spend most of my time actually treating what's referred to as non-melanoma skin cancer, basal cell and squamous cell carcinoma. I'm a Mohs surgeon, but I'm also part of the multidisciplinary melanoma program at the University of Michigan that many, if not all of you, are well familiar with. And as you know, dermatology plays a big role in that. So Chris asked me to talk to you a little bit about what we termed the national opinions on the state of melanoma. That sounds a lot more impressive than it is. But essentially kind of the things that are going on a national level. I have the fortune of being involved with several national guidelines on melanoma. And so I'm going to give you a little bit of a, not go through the guidelines, but give you a little bit of a sense of what goes on to create those guidelines and some of the dilemmas that we face when we're putting together these guidelines. But at the same time, I'm also the only dermatologist this morning, so I'm going to also wear a different hat and be the person to go over some of the basics of melanoma. Many of the things you know, but many of the things that just maybe are in the past and are helpful to you and maybe family members as well. So I'm going to wear two different hats this morning as we go along. So let's see here. It is. There we go. Okay, so let's start very, very basic. What is melanoma? As everybody in this room knows, it's a form of skin cancer that originates from particular cells in the skin called melanocytes. And those melanocytes are the pigment-producing cells that are located right here at the junction of these two main layers of the skin, the top layer being the epidermis, and the bottom layer here being the dermis, and the melanocytes reside right here at that junction. And so if those particular cells turn cancerous, we talk about melanoma. Other cells in the skin can turn cancerous as well, and those are called keratinocytes. Those are essentially these purple cells here, and those are the ones that can give rise to basal cell carcinoma or squamous cell carcinoma or other more rare types of skin cancer. So they all kind of originate in the same area, but from different cells. Once those cells grow, as you know, as long as they stay limited to that top layer of the skin called the epidermis, then we talk about melanoma in situ, and that's a word that's used in other cancers as well. It means that the cancer cells are still in the place where they originated. Once they start to grow out of that original place, the epidermis, and grow into the deeper layer of the dermis, that's when we talk about invasive melanoma. Synonyms that you will see: malignant melanoma, cutaneous melanoma, they're all the same things. There is unfortunately no such thing as a benign melanoma, so a malignant melanoma is it's melanoma or not. Who gets melanoma? Well, you can look around and see that we're all pretty much the same skin tone here, and we are the people who get melanoma. Lightly pigmented Caucasians have by far the highest incidence. Yes, there are people of darker pigment who get melanoma, but it is by far a much, much smaller group of people. The vast majority are, as I said, lightly pigmented Caucasians. Purely statistically speaking, in the US, invasive melanoma has now become, and has been for a while, the 5th most common form of cancer in men, and is the 7th most common cancer in women. So it's clearly something that is quite prevalent. If you look at this specific age group, Caucasian women between age 25 and 29, melanoma is the most common form of cancer. Now, of course, this is a group that doesn't get a lot of cancer anyway because they're so young, but within this group, melanoma is the most common form. We can blame it all on the tanning booths, but there's no question that there's probably some correlation there. And that incidence has been increasing quite dramatically, actually. So if you look at these numbers, so this is the lifetime risk for somebody to develop invasive melanoma. This does not include melanoma in situ, which is a pretty big group of people as well. So if you're looking at invasive melanoma, the lifetime risk of somebody born in 1935 to develop melanoma in their lifetime was about 1 in 1,500. For somebody born in the year 2010, includes most of my kids, the lifetime risk of developing melanoma, invasive melanoma, is 1 in 50. So there's been a dramatic increase. And we'll talk a little bit about what are some of those reasons. There's no question that one of those reasons is that we're finding more melanoma and we're diagnosing more melanoma. There were many people who probably had melanoma which was undiagnosed. People are living longer in general. In the 19th century, a lot of people didn't live long enough to develop skin cancer, so there's that issue as well. But clearly there are other things that are going on as well, and there's, as I said, a quite dramatic increase. This is what I'm sure you've all seen this website. It's really actually a very helpful website. I use it every time I give a talk because I can find a lot of statistics there, but there are statistics that are geared towards physicians, there are statistics that are geared towards patients. So according to the American Cancer Society, the estimate is that in the year 2015, in the US alone, there will be 73,870 diagnoses of, again, invasive melanoma. That does not even include melanoma in situ, which probably adds at least another 50,000. So it's a big number, but I have given this talk, or a talk on melanoma for many years, and I always kind of use this slide and go to this website and pick out the number, and this is the first year that that number has gone down. Every single year when I've made this slide, it's always a few thousand more per year. This was last year. This is the first time I've made this slide, and the number is actually going down. So I thought that was a very hopeful thing. So I am a dermatologist. I need to talk a little bit about the sun, and not talk about the sun when we're talking about melanoma. What causes melanoma, and sun exposure, specifically ultraviolet light, plays a huge role in that. We all know it's not the only thing. There are definitely other causes for melanoma, but it is an enormous part of it. Yes, there are people who carry certain gene mutations that put them at a higher risk for melanoma. Yes, we all know that there are families in whom you see multiple people with melanoma clustering, but the reality is that the vast majority of people whom we see don't have a family history of melanoma. And if they do, then it's probably more related to the fact that their family members all have the same type of skin. So, if you're of Irish descent, your family members are of Irish descent, and you all have a higher risk of developing melanoma because you are fair-skinned, not necessarily because you have a particular gene that increases your risk for developing melanoma. So the sun plays an enormous role. But you can nuance it a little bit more. And as a dermatologist, I see with different types of skin cancer. And for melanoma specifically, it appears that this periodic intense sun that we all had from blistering and peeling sunburns, particularly in childhood, plays the biggest role in the development of melanoma. Which I personally think is why we see a large number of people with melanoma in Michigan. When I lecture throughout the country and people hear about the size of our melanoma program in Michigan, like, really, in Michigan? You would expect that in Florida or in Texas or in California because they have more sun. Yes, they do have more sun. First of all, there are more darker pigmented people in southern states. There's that part as well. But at the same time, it's also the type of sun exposure. What happens to us in Michigan? Unless we travel throughout the winter, pretty soon we're going to start huddling up inside, and we're not going to come out until March. So when we come out in March, our skin is pasty white. And by the time we get to March or April, we're so fed up with being inside, the sun comes out, we all go out, everybody takes their shirt off. We see the students walking around with shorts in March. And they get a sunburn because their skin has been protected for all that time. So in that sense, Michigan kind of has the quote-unquote ideal climate of having these intense bursts of sun exposure on otherwise protected skin, and that's when you get those sunburns. And it is thought that those sunburns, again, that most of us had, in our teens and 20s growing up, play a particular role in melanoma. Probably a similar role in basal cell carcinoma. As opposed to squamous cell carcinoma, another form of skin cancer, that's probably much more related to chronic sun exposure. So, if you think of the people who spend, for their work-related issues, spend a lot of time outside, yes, we do see melanoma on the face, and it does occur here, but the most common places are, as we'll go through in just a minute, are the areas where we have most of our sunburn. So it's a little bit different for different skin cancers, but melanoma specifically is related to these bad sunburns. So a few words about sunburns. The statistics say that one blistering sunburn, and who hasn't had one blistering sunburn, in childhood more than doubles your risk of developing melanoma later on in life. And so it's a little bit hard to do these statistics because it's, you're asking people at the end of the summer how many sunburns did you have, and so it's not super accurate, but at least in the studies that are out there, and when asked, 72% of youth 11 to 18 report at least one sunburn per summer, and 1 in 9 of them have had 5 or more sunburns, and that's the reality. I mean, we know that that's how it is. And if you look nationally among white adults, it is the Caucasian adults in the Midwest who have most of the sunburns. And I think, again, it has a lot to do with what I was saying earlier. This picture actually is interesting. I've had this picture in my talk for years, and one day she called me. And she said that she was a medical student and had come across this talk, and my first thought was like, oh my goodness, she thinks that I've been using her picture without her permission, and then I thought back, and I actually got this picture from the American Academy of Dermatology website, so I felt like, okay, I used a case source, but she was not aware of that. So anyway, I of course is the poster child for somebody who would develop melanoma, but she actually is in medical school. I don't know whether she went to dermatology, but she was interesting. So where does melanoma occur? And it has a lot to do with what we just talked about. Intermittently exposed skin has the highest rate. So again, it's not the face. Yes, we do see melanoma in the face, but it doesn't have the highest rate because of what we just discussed. And that's particularly in the younger group of people who develop melanoma. Young is all relative, I know that. But in men, and again, it has a lot to do with sunburn patterns, the trunk is the most common place, the upper back. And again, if you think about it, that's where you get most of your sunburns. In women, actually, the lower legs are the most common place, followed closely by the trunk as well. So again, areas that are often covered up, but then are exposed and just develop sunburns. There is this subgroup of melanoma, and I'm sure you are aware of it, something referred to as lentigo-malignant melanoma. It's not a different, it's all melanoma, and they all behave in a sense the same way, but they develop a little bit differently. And so melanoma, and this lentigo-malignant melanoma is the type that does develop more on chronically sun-exposed skin. It is, as opposed to kind of the more conventional melanoma, in which the mean age is about somewhere in the 40s to 50s. Lentigo-malignant melanoma is much more common in 60s and 70s and beyond, and that is probably more related to chronically sun-exposed skin, to chronic sun damage, just like squamous cell carcinoma. But, as I mentioned, melanoma can also occur in other places. The sun is not the whole story. These are more rare presentations, but they certainly occur, and obviously none of these have anything to do with sun exposure. So we can talk a lot about the sun, but it's important to remember that there is definitely that subgroup of melanoma that has nothing to do with the sun. Mucosal melanoma, which develops in the mouth, is actually quite rare. It really doesn't happen very often. This, of course, is in this person a sun-protected place. In my case, it would not be sun-protected, but in this case it is. Acrolentiginous melanoma, so on the palms and soles, there's sometimes some confusion about that. There's a sense that it occurs more frequently in African Americans or in general people with darker pigment. That's actually not true. The incidence is the same among everybody. Because it's not related to the sun, every race, every age has the same risk of developing acrolentiginous melanoma. In African Americans, it is almost the only type of melanoma that develops. Bob Marley had acrolentiginous melanoma, if you knew that. And so therefore there's that sense that it's more common among African Americans. It is not. It is equally common among all races. So I showed you those lines of how melanoma is increasing, how we're seeing it more commonly. Why is that? Is there more sun than there used to be? Is the ozone layer thinning? Yeah, it could be. Some of that could play a role. As I said, we're diagnosing more. But really, if you think about it, what has changed probably the most is just social behavior. Look at this slide. These are railroad workers in the early 1900s, working somewhere in the west of the United States. There's not a single person who's not wearing a hat. There's not a single person who's wearing short sleeves or shorts. All of them, in spite of what is probably the heat of where they are protected. Except their hands and faces are protected. And so we've learned a lot, haven't we? So, social behavior has changed dramatically. There is much more skin exposure. Just being tanned has become fashionable. So, right there, is an enormous change in social behavior that probably plays a big part in why we're seeing so much more melanoma. This is hardly a very scientific slide, but I always think it's interesting. So, because you can relate the increase of the number of melanomas to certain things, and again, it's not the only thing, but there's certain interesting things that happen. And probably, in my mind, one of the biggest things is actually what happened in the 1920s, and it was actually Coco Chanel who introduced that, was this dramatic shift from a tan being something that was referred to as something undesired, right? If you had a tan, it meant that you didn't have enough money to be inside, that you had to go outside and work. So socially speaking, it was much more desirable to be fair because it meant that you were rich enough to be inside. If you had to go outside and work, then you had a tan. The story goes, and I don't know how much truth there is to this, but the story goes that Coco Chanel, the famous fashion designer, was on a train with a balcony from Paris to southern France, and during that trip got tan, and thought, hey, this actually is not such a bad look. And whether that particular story is true or not, what is true is that she's the one who coined the idea that having tan skin was a healthy thing, was a good-looking thing, and was something that was desired. And so that was really the big shift. And so we went from it being undesirable to desirable to have a tan. In 1946, the bikini was introduced, which I learned was actually named after the atomic tests that were done in the bikini atolls. That's why it was named that. But that was both in 1946. So obviously a lot more skin was being exposed. It took a little while until as much skin was being exposed as now, but more and more. And then, of course, later, and not so long ago, in the 1970s, tanning booths were introduced. And again, we can't blame all these specific things for all of the melanomas, but it's played a very significant role. So a few words about tanning booths. We've heard about it already. And these are some fairly well-accepted statistics. It's felt that the risk rises 75% when indoor tanning begins before age 30. In reality, we know that it almost always begins before age 30. That's when most people start doing this. More than 30 million Americans use indoor tanning, more than 1 million on average day. It is a huge industry. 5 billion annual. I mean, you remember the fights that went on in the tobacco industry several years ago when dealing with lung cancer. It's not as big as the tobacco industry, but it is a huge industry. So trying to tell this industry that it's a bad thing obviously causes a lot of people to try to fight that concept. You said 11, and then what I don't know where centers went, but I just read that 13 states have now banned the use of UV tanning devices under the age of 18, so for minors. California was the first in 2012. So under the age of 18 in these 13 states, in California and Texas are some of them, they cannot be used under 18. At least 42 states have some type of regulation, and some of them don't have anything at all. In Michigan, the law at the moment is that in person, and I actually wonder whether that truly happens, but the law is that in-person parental permission is required for minors under 18 to use these devices. This is the latest map that I found, apparently in May of 15. So in red are the states in which it is completely banned under 18. The orange ones is where there is at least a partial ban, so some of them are banned under 14, for instance. The yellow states is where there is at least some type of restriction, just like in Michigan, and the white ones is where there is nothing at all. So we're moving ahead, but we're not there yet. And I found this, it's I mean, if you think about it, and if you look at some of these devices that are available, and I just learned actually this just a couple weeks ago, a few medical students wrote an article here that was published in one of the university publications that, I didn't even know this, that there are a lot of not dorms, but student housing in Ann Arbor that will try to lure students to come rent an apartment and have free tanning booths in the buildings here at the University of Michigan. I mean, not as part of the Michigan, but apartments. So it's quite widespread. So some risk factors for developing melanoma. We talked about UV light, both sun and artificial UV sources play a big role. But as I said, it is of course the combination of this with your skin type. And so that's oftentimes where the genetic part comes in, just the susceptibility to get sunburns from this UV light. So light-based skin pigmentation, longer red hair, blue or green eyes, prominent freckling, tendency to sunburn. All those things put together will increase your risk from having a sunburn from the sun. And as we have learned, the sun crosses party lines. And you know, anybody with this type of skin, you know, I'm sure you know that John McCain had melanoma. That in fact I'm pretty sure was stage 3. Actually, President Carter was, as far as I know, he didn't have a primary skin melanoma, but he must have had at one point and developed melanoma metastases. Certainly, you know, he fits the picture very well of the fair-skinned, light-eyed, growing up in Georgia on a peanut farm, so he certainly fits that picture very well. Other risk factors that are not related to the sun are simply moles, or what are referred to as nevi, the plural of nevus. So there are two ways that are considered risk factors for melanoma. One is simply having a ton of moles. And so an adult with more than 100 just typical moles is considered a risk factor. Children with more than 50 moles, that's actually quite a few. If you start counting, most people think they have a lot of moles, but if you count them, it's not nearly as much. This person clearly does, obviously. So that's the quantity of moles. And the other part is the quality. So atypical moles, I'm sure you've heard the term dysplastic moles, dysplastic nevi. Having those in and of itself are considered a risk factor. Now here's the part that's often misunderstood. These dysplastic moles, these atypical moles, are not necessarily a risk factor for developing melanoma in them. In fact, most melanomas don't develop in a pre-existing mole. So a very common occurrence is somebody has just been diagnosed with melanoma. It was an early lesion, it's been removed. Let's remove all of my moles. Because if I remove all of my moles, then I'm not going to, I won't get another melanoma. It unfortunately doesn't work that way. Most melanomas don't arise in a pre-existing mole. But having a lot of moles, or having some of these dysplastic nevi, is just an indication of what type of mole your skin is able to make, and that in and of itself is considered a risk factor for developing melanoma. So it's an independent risk factor. How do we detect them? You're all very well familiar with the ABCDs, the asymmetry of the mole, the irregular border, the different color. The D is what we used to refer to as the diameter. But as you all know, I can't tell you how many times somebody came in and I asked them what their melanoma looked like and say, well, it didn't look anything like the ABCDs. And that happens all the time. This is helpful, but in reality, I tell most people, if it violates these ABCDs, anybody would recognize it. It's the other ones that you like you don't recognize quite as readily. And so that's why we have kind of changed this D, because the reality is that this is not a very helpful thing. There are many lesions that are bigger than 6 millimeters that are not melanoma. There are many melanomas that are less smaller than 6 millimeters. So we've kind of abandoned this diameter a little bit and focused much more on the word difference, and that's really what we use for this letter D. Difference in two different ways. Most importantly, something that is changing over time, as you know, and most people will say it may not have looked like the ABCD, but something was changing. It was changing in size, it was changing in color, it was changing and it became raised, it was itching, it was bleeding. That difference in a mole is really probably one of the best ways to detect a melanoma. And different in a sense, different from the others. So something that stands out and looks different than your other moles. Something we refer to as the ugly duckling sign, something that stands out. This is a slide that I used to teach our medical students this concept of the ugly duckling. So if you look at somebody, and if you think of all of these as being moles, they all look the same. And maybe they are slightly irregular, maybe they're slightly asymmetric, but they kind of look the same. They all kind of fit in the same family of moles. Now one of them is a little bit different, but still the overall pattern is the same. So this may be what you would describe as a dysplastic nevus. It's a little bit different, but it still kind of fits within the family of moles. Now if you see something that's completely different, that's a cancer. That needs to be removed. The point is, it's the ugly duckling. So this is where I'm going to switch gears for a moment and put on a different hat and talk to you a little bit about these national guidelines and how we come to them and what implications they have. I've gotten involved with a few of them, both the American Academy of Dermatology and the NCCN, the National Comprehensive Cancer Network, but there are tons of them. There are guidelines all over the world. And one of the most important things that I learned by getting involved with these was first of all, just this, and seeing how many guidelines there were. And there were really a few things that struck me. First was some of the things that we as physicians, we as dermatologists and surgeons do every day, and we kind of think is common treatment and is all based on all this, huge amounts of evidence. Sometimes there isn't. Sometimes we're doing what we're doing because we've been doing that for many years, but there really maybe isn't that much evidence to support that. As for instance, as Dr. Sable will talk to you about, like the margins that we take, there's always that much evidence for that. Sometimes there isn't. On the other hand, some of the things that we think are very controversial, and I will talk a little bit about the sentinel lymph node biopsy, and you may or may not be aware that there remains controversy about the use of that. There's actually a lot more consensus about the use of sentinel node biopsy among all of these different guidelines than you would think there is. So that was comforting. And at the same time, just as I said, knowing that there are so many different places looking at this is helpful and rewarding to know that that's the case. So as I said, there's much more consensus among these than you may think, and so it's kind of telling us we must be doing something right if everybody looking at this data is kind of coming to similar conclusions. This is the NCCN. I'm sure many of you are aware of it. I just want to make you aware if you are not. So it's the National Comprehensive Cancer Network, which has guidelines for the treatment of just about every cancer known to man. Certainly the most common ones, but even, as you've heard from Dr. Lau, we deal with something called Merkel cell carcinoma, which is a very rare type of skin cancer. We have a guideline for Merkel cell, the NCCN, basal cell, squamous cell, cell, ovarian cancer, colon cancer. So if you go to nccn.org, you will find these algorithms on the treatment of all these different cancers. And those are, let me just go back for a second. I'll show you some of these examples. These are really meant for clinicians. These are meant for physicians to kind of help them guide in the treatment. But there is also, not for all of them, but there is for melanoma, a patient version of those guidelines. And if you haven't already seen this, you should take a look at it. It's really a terrific document. It's very, very clear. It goes over just about everything from, types of melanoma, some of the things that I talked about, prevention, specific treatments for melanoma, and then also more general things about, just treatment decisions, more in general in oncology, and then necessarily melanoma specific. It's not so easy to get a hard copy, but if you have a computer at home, the PDF that comes up, this is really cool. You hit the button and the pages turn like that. It's a very nice document to look. I wish we could provide that to all of our patients, but we can't. It's a big booklet, and NCCN doesn't give them out like that. So if you haven't already seen it, it's worth looking at. The algorithms that are, again, more for clinicians, kind of look like this. All the different pages look like this, and that's really what it is. So the idea is to help, and I'm not going into the details here, but it's to help a clinician who is in the community, or anybody, who may not deal with this on a daily basis, to say, okay, if I'm dealing with melanoma in situ, what do I need to do with that? If I have a more deeply invasive melanoma, which pathway do I need to follow? What test is recommended? What test is not recommended? What kind of follow-up do I have? So these are very comprehensive and are being used by more and more clinicians in the United States and also abroad. And so it's extremely helpful. It's being used in many other ways as well, and that's kind of one of the things I wanted to touch on. When we're writing these algorithms, it's not just clinicians who are looking at this, it's not just patients who are looking at this, but it's also insurance companies who are looking at this. So if the NCCN says that for this particular stage of melanoma, we recommend that you don't do a CAT scan. Now this patient goes and sees Dr. Lau, and Dr. Lau wants to do a CAT scan, and the insurance company says, well, wait, the NCCN says you don't need a CAT scan, we're not going to pay for it. So as we make these guidelines, it's very important that we consider all these things, because it is being used more and more, and it's kind of become the go-to place for, as I said, both for physicians and insurance companies to see whether something is indicated. So what I wanted to do is just kind of give you a few examples of some of the things that we have discussed in these NCCN panels over recent years, and just not going into the details of the actual decision, but how these things came about. I just wanted to mention this, so you may or may not have heard of this, and this is probably more relevant to people who are currently being diagnosed or diagnosed very recently. But there's this concept of gene expression profiling. And so what this essentially means is, wouldn't it be nice if you diagnosed a melanoma, you did a skin biopsy, and you could do a test on that melanoma that would tell you at what risk, what's the risk of this melanoma behaving aggressively. If you could just do a test and say, oh no, based on this genetic profile of this particular melanoma is not going to spread anywhere, or this melanoma is. And you could adjust your treatment according to that. We all would like that, right? I mean, that would be the ideal thing. So there are many places that are looking to do just that. Can we determine a particular genetic profile of this melanoma that's going to tell us exactly how it's going to be? It's going to tell us whether we need to do a lymph node biopsy, or maybe in the future, we wouldn't even have to do a lymph node biopsy. So there are such tests available, and they're being done, and one of them is this. It is called DecisionDx-Melanoma. It's made by Castle Biosciences. And if you go to their website, as you may or may not have done, if you go to their website, this is what it says. DecisionDx-Melanoma, proven to identify high-risk disease, impacts patient care. And if you read this, it sounds like this is the end-all, be-all. We all need to do this whenever we do this test. So you can imagine that people, out in the community, they see a dermatologist, they see a doctor who doesn't see a lot of melanoma, like, oh, we need to do this test, which is going to tell us, what we need to do. So if you look into, and that's not the point, but if you look into the data, if you look into the studies, we're really not quite there yet. And so that's one of the things that we tackled at the NCCN. This is the main take-home. And so this is the page, and I kind of blew this up for you because otherwise you can't see it. So after looking at the data in the NCCN and looking at it carefully, the whole panel came together. There were a few panel members who actually were involved with the company, and they didn't get to vote on this. So the conclusion was, while there is interest in newer prognostic molecular techniques, such as gene expression profiling to differentiate benign from malignant neoplasms, or melanomas that are high risk or low risk, routine genetic testing of primary melanomas is not recommended outside of a clinical study. So this is it's an important statement to make. It also means that an insurance company, will probably not pay for this because of that statement. But so it's a place like this where you can go to for that information and know that, an expert panel has looked at this and said, look, it's interesting, we want this to happen, but we're not quite there yet. Sentinel lymph node biopsy. Many of you in this room may have had a sentinel lymph node biopsy. If not, you've probably heard about it. It's a staging test. It's a test at the moment. It does just that, what we're trying to achieve with that genetic profiling. How did this melanoma behave? If the melanoma was here on somebody's trunk, as you know, the site is injected with a dye. Dr. Sable will probably talk to you more about it. The dye travels to a lymph node, and the feeling is that that's the lymph node that a melanoma cell would go to as well. Dr. Sable removes that lymph node. It is then sent to the lab and looked at to see whether you find melanoma in that lymph node. My point is not talking about the lymph node biopsy, but my point is, again, from the NCCN perspective, who should have that test, right? In a sense, you'd say, well, I want to know that for every melanoma, whether it has spread or not, so let's do the test. Well, Dr. Sable has to take you to the operating room and put you under general anesthesia to do that test. So if the risk of this melanoma spreading somewhere is very low, really low, does it really justify going to the operating room and putting you under anesthesia to do that? No, probably not. But where do you draw that line? Who should have the test and who shouldn't? So that's a big discussion in the NCCN. It has been that way for years. It's a big discussion. Dr. Sable talks about this at national meetings. Where do you draw that line? So that's one of those things that we discuss, where that line is drawn and where it makes sense. And that's where you kind of have to weigh, your personal feelings versus, the big picture. Because the big picture does become important as well. We had this discussion once where there was a very strong push to lower the threshold to do the lymph node biopsy. Let's do it for thinner and thinner melanomas. And so we at one point just made this calculation, say, okay, because traditionally, as you probably know, typically a melanoma of 1 millimeter in depth is kind of where that threshold has been drawn. If you draw that line and lower it from 1 to 0.75 millimeters, and so we're essentially saying that if the risk of it being in a lymph node is about 5%, 1 in 20, we should be doing this test. It means that you would increase the number of these procedures done in the US by almost 9,000. That's a lot of procedures. That means that a lot of people are getting the test. And it also means that a lot of people are getting the test, who have a negative lymph node. So, you can see how it's not easy to make those decisions where that line is drawn. Because at the end of the day, it's not all about statistics. In fact, it's not about statistics. And it's at this point that I'd like to quote, some data from, this is not melanoma, this is the breast cancer literature, where they asked a very simple question. They asked women who had undergone treatment for their breast cancer and then underwent adjuvant, this is studies from 2005, so at that time they would get adjuvant chemotherapies. In other words, the surgery had been done, the radiation therapy had been done, all the cancer was gone, but then they underwent 6 months of chemotherapy to hopefully prevent it from coming back. And the patients were asked, what was it worth undergoing those 6 months of treatment, which was not negligible. I mean, this is 6 months of chemotherapy. What was it worth? And the answer was that half of the women judged that a 1-day improvement, or a 0.1% improvement in their survival, warranted undergoing those 6 months of chemotherapy. Now, when they asked that same question to the oncologists and the nurses who were administering those drugs, they gave a very different answer. They said, well, I wouldn't undergo those 6 months for a 1-day improvement. But the patients who actually had the breast cancer did. So it's very important for us as clinicians to realize that there is this discrepancy between what we may think as physicians, what we may think on an NCCN level, and what is on a daily basis. So it's something we need to be aware of. I hope this has never happened to you, but we all know that that's what we're trying to avoid. It's not Dr. Lowry's. In imaging studies is another one of those. CT scan, PET scans. Why don't we do PET scans every other month to see whether melanoma or any other skin cancer has spread somewhere? In a sense, you want to. At the same time, you don't want to expose people to more radiation than you need to. You don't want to expose people to the anxiety of finding all sorts of things that are abnormal on a CT scan when it's really not relevant to their melanoma. So it's another area of the NCCN where there's a lot of discussion. Who needs a scan? How often do they need it? When do they need it? What's an appropriate indication? We sometimes see people who have been followed by outside, doctors, and they're getting PET scans every 3 months for the last 5 years. You think that's exaggerated, but it actually happens. Clearly, that's not necessary. It's leading to a lot of radiation exposure. It's leading to a lot of cost. It's leading to a lot of anxiety that really wasn't necessary. So all of these things are kind of discussed in these guidelines. Another one that I'm involved with is the AAD, which is the American Academy of Dermatology. It's a different set of things that we look at, maybe not so much on the CT scans and things like that, but at a different level. But it calls for equal discussion. The biopsy of the original melanoma seems pretty straightforward, right? You come with an abnormal lesion, you go to the dermatologist, they do a biopsy. Well, the biopsy technique is very different. And so we've had long discussions in these groups. There are surgeons who say, well, look, you don't want to transect your melanoma because you need to know what the Breslow thickness is. So every single melanoma needs to be excised. You need to cut it out and put stitches in. Well, that's what it was important that dermatologists are on these panels too, because they say, well, wait, do you have any idea how many lesions we biopsy on a daily basis? We can't excise all of them. We'll never get to all of them. So we came up with this type of wording. The preferred biopsy technique is a narrow excisional biopsy that comprises the entire breadth of the lesion with blah, 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 blah. This whole description. But it actually describes it very nicely exactly what we want. My point is, again, there's a lot of thought that goes into exactly what needs to be done and needs to be described clearly so that clinicians know how to guide their treatment. I'll end with just a brief historical note and just kind of show you how we have come a long way. Dr. Hunter in 1787 is credited with having excised the first melanoma. He had no idea that that's what he was doing, but he was. In London, he described it as a cancerous fungus excrescens from the jaw of a 35-year-old man, and was put in formalin, and many years later was actually turned out to be a melanoma. So that's, as we know, the first excision of melanoma. About 30 years later, Dr. Handley described the treatment of melanoma. I won't go into a lot of details, but based on a case that he examined very carefully, he recommended that melanomas be removed with a 2-inch margin, 5-centimeter margin. If you have come across people who have had their melanoma treated in the 1970s or earlier, they have these enormous excisions on their back with a big skin graft on there. That is all based on Dr. Handley's description from 1907 in the Lancet. We've come a long way since that time, and we don't do that anymore. So it's not perfect, there are still a lot of room for improvement, but my point is that with all these guidelines that are out there, that are all very similar, are all kind of heading in the right direction, I think our treatment has improved so much over the last century. And with the help of all these people from all these different countries, I think we're heading in the right way. And I think because of that, and because of some of the things that you'll be hearing later this morning, the future actually is much brighter than it appeared to be for many years. For quite a while now, have had a good handle on the treatment of early melanoma, but obviously what we'll be hearing later today is the treatment of advanced melanoma, which has improved so much. So I really do think that there's a bright light at the end of the tunnel. And just to show you what actually is behind that bright light,